Welcome to the Demonstrating Implementation Excellence stream of SNOMED CT Expo 2024. Thank you to FAST for sponsoring this stream. My name is Sonja Ulrich and I'm the Software Development Manager at SNOMED International. I will be moderating today's session. All questions will be answered at the conclusion of this presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone provided in the room. I'm now pleased to introduce Julie Boutin from Canada Health Infoway and Tammy Lau from the Canadian Institute for Health Information, who are presenting using SNOMED CT to enable interoperability in the organ donor-recipient patient journey and system-level performance reporting. Julie and Tammy, please go ahead.
Well, hello, everyone. My name is Julie Boutin. I'm a Senior Standards Specialist at Canada Health Infoway. So with the help of my colleague Tammy, I would like to introduce you to the implementation of SNOMED CT in the Canadian Organ Donation and Transplantation Data System. So let's start with a brief presentation of our two organizations. So Canada Health Infoway is the Canadian Standards Release Center for SNOMED CT in Canada. Infoway is an independent, not-for-profit organization funded by the federal government that works with governments, healthcare organizations, clinicians, and patients to make healthcare more digital by ensuring that everyone is able to access health information and services online. So I'll now hand over to Tammy, who will introduce you to the organizations she represents and give you a brief overview of the project.
Hi everyone, my name is Tammy and I'm a data analyst from the Canadian Institute for Health Information, Organ Donation and Transplantation project team. The Canadian Institute for Health Information, or CIHI, is an independent, not-for-profit organization that provides essential information on Canada's health systems and the health of people living in Canada. We work closely with the federal government, provincial and territorial ministries of health, and other partners and stakeholders throughout Canada to gather, package, and disseminate information to inform policy, management care, and research. We also manage over 30 data holdings across different healthcare sectors with the mandate to deliver comparable and actionable information to accelerate improvements in healthcare, health system performance, and population health across the continuum of care. Now I'm going to start with an introduction to the Pan-Canadian ODT Data and Performance Reporting System project, called the ODT project for short, and how CIHI and Infoway are collaborating on this project. The ODT project is a multi-year project that is funded by the federal government and co-led by CIHI and Infoway, with the goal to develop a modernized ODT data and performance reporting system to address challenges faced by the Canadian ODT system. In Canada, the need for life-saving organ transplants exceeds availability. In 2023, 3,427 Canadians were waiting to receive a transplant, and while 3,428 transplants were performed that year, 214 people died while waiting. As well, Canada underperforms in measures such as rates of living and deceased donations when compared to peer countries. Furthermore, there remains variations across Canada in organ donation rates and access to transplantations. ODT systems often still rely on paper and phone for day-to-day clinical operations, and there are challenges in incomplete data, multiple systems with little to no integration, inconsistent use of data standards, and limited performance reporting. In a report by the federal government, it was noted that the lack of a pan-Canadian data repository and system performance indicators is the Achilles heel of the pan-Canadian ODT system. This led to the initiation of the ODT project, with both CIHI and Infoway given the mandate to partner in developing a modernized ODT data system in collaboration with jurisdictions and the broader ODT community. Having a more modernized ODT system will help us better understand the system challenges, support evidence-based decision-making, and drive improvements in access, quality, and better patient outcomes for both transplant recipients and donors. The ODT project scope is defined by 3 work streams which are led by either CAI or Infoway, although both organizations work closely with each other to complete project activities and achieve key deliverables. The Data Standards and Repository workstream is led by CAI, where we developed new Pan-Canadian data content standards and minimum data sets to support data collection, as well as the creation of a new Pan-Canadian ODT data repository. The Digital Solutions workstream is led by Infoway and is responsible for procuring, deploying, and integrating point-of-service solutions for the collection of ODT data. Lastly, the Reporting and Access workstream is led by CAI and is responsible for prioritizing and developing ODT indicators and measures for health system performance reporting based on extensive consultations and engagements with a wide range of stakeholders across the country, as well as producing timely, public, and secure reporting and data access. As previously mentioned, one of the key deliverables was the creation of a Pan-Canadian ODT repository, the Canadian Organ Donation and Transplantation Data System, also called CAN-ODT for short, and which is CAI's newest data holding. CAN-ODT has 3 modules to receive digital deceased donation, transplantation, and living donation data via APIs, which supports a more seamless, automated, and timely flow of data to CAI. CAN-ODT also allows for longitudinal following of patients, donors, and organs. As well, another key deliverable was the development of 3 Pan-Canadian minimum data sets for these modules, which have been embedded into the digital solutions to support interoperability. These minimum data sets can be found on our website, caihai.ca/ODT. The CAN-ODT minimum data sets, or MDSs, outline the data elements and values needed to support data collection, indicator development, and health system performance reporting. This slide shows an example of what the MDS looks like. Here we have the data element name, donor blood type, description, and value set. These MDSs capture data through the donor and recipient patient journey and were developed through consultations with stakeholders to ensure that what we collect and report on is most important to the ODT community and supports the project's vision and intended outcomes. An important consideration when developing our MDSs was to promote data standardization and interoperability. To accomplish this, the majority of coding for the CAN-ODT values were sourced from established standards such as ISO, HL7, LOINC, and most notably the SNOMED CT Canadian edition. On the slide here in the value set, we can see that the first 4 values, blood group A, B, O, and AB, are sourced from the SNOMED CT Canadian edition, and UNK is sourced from HL7. So why did we choose SNOMED as one of our standards? First, SNOMED has comprehensive clinical coverage and can capture the more detailed ODT clinical concepts. Its granularity can also support future CAN-ODT MDS enhancements as needed. Second, SNOMED is a standardized clinical reference terminology, which allows for consistency and comparability of data, minimizes ambiguity, and can facilitate more accurate data collection and improved reporting. Third, SNOMED allows us to have improved interoperability through seamless integration and data exchange with organ donation organizations and transplantation centers, which are the organizations in Canada that send ODT data, as these systems are ready in the future. Lastly, we specifically use the Canadian edition as it's the preferred clinical terminology in Canada, and Infoway is the Canadian Standards Release Center. It has a quarterly release schedule, English and French subsets to support bilingual content, as Canada's 2 official languages are English and French, and allows for additional customization based on the Canadian healthcare context. This slide shows a map of Canada with the number of organ donation organizations and transplant centers in each province and territory. As we can see, the current state is a mix of paper and electronic documentation solutions. So the goal of the digital solutions that Infoway is leading, and with the CAN-ODT MDSs and standards embedded in them, is to improve workflow efficiencies and advance interoperability in ODT systems across Canada through the deployment of modern data management solutions and integrating systems. The procurement and deployment of modernized data management solutions would replace outdated systems and reduce reliance on paper, email, fax, and phone, allowing for greater efficiencies and cost saving across systems. And the integration of existing and newly deployed data management solutions will reduce duplicate data entry, system inefficiencies, and fragmented workflows. I'm going to pass it off to Julie for the next part of this presentation.
Thank you, Tammy. So let me now briefly explain how these two organizations have worked together to make the request for change process to create a new SNOMED city content more efficient. So as Tammy explains, the minimum data set was developed by CAI in collaboration with a group of clinical experts. The data to be standardized was identified by this team, and requests for change for the creation of new concepts were submitted to InfoWay. So InfoWay then proceeded with assessment of the request without knowing the context of use. There were therefore a lot of questions and back and forth between the requester and the SNOMED City team, for example, to understand the exact meaning of a concept, the context of use, etc. So this is why we decided to set up working meetings with the key people from both teams. So in these working sessions, a brief introduction to SNOMED City, including the different hierarchies and some editorial rules, was provided by the InfoWay team, while the CAI team presented the context of use and explained the project requirements. So as a result, several requests for change were withdrawn or canceled by CAI. Some were resubmitted, taking into account the previous discussion. And finally, the SNOMED City team was able to complete all the requests for change for this phase. So here is a summary of the requests for change submitted and their final statuses, which illustrates the difficulties of the process. So out of a total of 149 RFCs submitted, only about half met the criteria to go through the whole process. 7 concepts were then submitted to SNOMED International for inclusion into the core, but I will come back to this a little bit later in the presentation. So for the second phase, as the collaborative working sessions had worked well for the previous phase, this was repeated, but this time earlier in the process. So the submission of requests for change was therefore done only after the working sessions. So the assessment and processing of these requests was then much easier and faster for the InfoWay team. So again, here is an illustrated summary of the statuses and the submitted request for change for phase 2. This time, not only more requests submitted, nearly 200 this time, but the majority of them were successfully processed in their entirety, and 5 more concepts were submitted to SNOMED International for core inclusion. So it is important to note that the success of these working sessions is also due to the presence of key players from each of the organizations. So the presence of both project team was essential, but also on one side, the ODT clinical experts were present to clarify the needs and requirements of the project. And on the other side, the data standards expert helped to better situate the request in the context of SNOMED City, but also to increase the quality of its content. So here we thought it would be interesting to present to you some situations where we have reworked requests for change together. So the first example of modification that we worked is of the rephrasing type. So the proposed description, as you can see, did not really follow SNOMED City editorial guidelines and naming conventions. So we propose to rework these descriptions to align with what currently exists in SNOMED City, as well as other values or other concepts for the same data element. So these proposals were then submitted to clinical expert on the CAI side for approval and confirmation that they still met the need before submitting requests for the creation of a new concept. So example number 2 is number 2 type is a change to the model. So at first, the need was to clearly represent whether the donor has a biological relationship with the recipient or not. So to facilitate the creation of the missing concept and to avoid mixing SNOMED City hierarchies for the same data element, it was proposed to divide the data element into two, biological and non-biological. So the minimum data set now first includes a question to specify whether the relationship between the donor and the recipient is biological or not. Then the biological and non-biological value sets are presented according to the relationship chosen in the previous step. So you may have noticed that only a small number of new concepts have been submitted to SNOMED International for inclusion to core. So this project did indeed lead to the creation of a large number of new concepts, but with a Canadian scope. So this is partly because much of the new content is specific to the Canadian ODT project, such as expressions or terms to identify different actors and locations, but also because concepts were created that were as close as possible to the SNOMED City Convention, but not entirely, in order to better meet the needs of the project. So as an example, for a registered intent to donate, so this is to represent whether an individual is interested in donating their organs. So however, the concept of having a registered intent to donate and registering yes, no, or opt-out registering may not be applicable in other countries with different ODT system. So similarly, type of offer is to capture the organizations involved in the organ offer, but this may not be applicable for other countries where the organ offer process differs from Canada. So I now hand over to Tammy for the rest of the presentation.
Thank you, Julie. As a result of Phase 1 and Phase 2 of the RFC process, we have created to date 104 new concepts and 170 new descriptions, which include 161 new descriptions in French. In terms of implementation into the CAN ODT MDSs, into deceased donation MDS, 52 data elements use SNOMED and 71 values are sourced from SNOMED. For the transplantation MDS, 49 data elements use SNOMED and 176 values are sourced from SNOMED. And lastly, for living donation, we have 24 data elements which use SNOMED and 50 values which are sourced from SNOMED. Through CIHI and InfoWay's collaboration in creating new SNOMED concepts and descriptions, we encountered a few challenges, but at the same time gained several valuable lessons learned. One of the biggest challenges was balancing the ODT and SNOMED requirements and needs. ODT is a niche, specialized area of healthcare, and sometimes there were difficulties in creating new concepts and descriptions that adhered with the SNOMED guidelines, its hierarchical structure, ensuring it has relevance and usability across other healthcare settings, and at the same time, balancing the needs of stakeholders with the ODT project's indicator development reporting requirements, and making sure that ultimately these newly created concepts still have the original intention and meaning and weren't far off from what our stakeholders wanted. So this was a huge balancing act that was quite a challenge in this project. Another challenge we encountered was implementation of SNOMED in vendors. Although the CAN ODT MDSs use the SNOMED CT Canadian edition, we found that vendors are often adopting the international version and other types of standards, which creates difficulties in mapping data to the MDSs, hindering their ability to capture and submit data to CIHI, and being able to achieve the interoperability that we envisioned for this project. However, through these challenges, we've learned that it's important to set clear objectives and to understand what data needs to be collected, why it's important, and how it will be used to drive decision-making. As well, having a defined scope is crucial when establishing a system to prioritize RFCs, identify those that are in scope and out of scope, those that require more consultations and work between CIHI and InfoWay, or may need to potentially involve other ODT subject matter experts. Lastly, it's important to involve key stakeholders earlier in the process to support the construction of the data model and thus avoid delays when processing change requests. In particular, the collaboration between ODT subject matter experts and data standard experts and specialists is essential and must take place at the right time. Ultimately, this project and the implementation of SNOMED in CAN ODT showcases the value of having national organizations with complementary skill sets in digital data, health standards, and health data, as well as the value of collaboration and engagement with a diverse group of stakeholders. We encourage you to visit our ODT project webpage to stay connected with our work. This concludes our presentation. Thank you for your time, and we'd like to open the floor for any questions.
Thank you.
Thank you, Tammy and Julie. Great presentation. Julie and Tammy are joining us now from Canada and will take questions. As a reminder, if you're in the room, please use the microphone. Any questions? No questions online? Okay, I have a question. Can you hear me? Yeah, okay. If you could start all over again, is there anything you would do differently, Julie?
Well, I think we talk about it in our presentation. So, for example, the working sessions. So I think it's a great lesson learned for the first part of this project. So I think we would put in place those working sessions from the start if we had to do it again. Tammy, do you have something more to add?
Yeah, I think if we were to start this process all over again from the beginning, definitely involving the data standards experts earlier, especially when we're in the beginning stages talking to the stakeholders, especially the clinicians who are informing a lot of the minimum data set, data elements, and values. While the clinicians definitely have an idea or they know what kind of values are important to inform health system reporting or are relevant for a clinical perspective, I think it doesn't always translate over well when we're developing these SNOMED codes and concepts and trying to fit it into the SNOMED hierarchy and use case and the editorial guidelines. So I think if we had the communication and the collaboration with the data content standards experts earlier in the process, that would have helped pave the way and make a lot of the later work go a lot more smoothly.
Okay, thank you. And what are your plans for the future? Where are you hoping to be, like, say, in 2 years? This all continues.
That's a really good question. I think from the Kai-Hai and ODT project perspective, we're definitely looking to continue our partnership with Infoway on all fronts as we continue to expand on the MDS or make changes based on stakeholder needs, especially from an implementation perspective. That will probably require a lot more ongoing work with the Infoway standards team to have to develop new SNOMED codes or to provide expertise and guidance to some of the vendors and the other provinces as they're implementing this into their systems.
Okay, thank you. Julie, what are your thoughts?
I don't have anything more to add to what Tammy just said.
Okay, thank you. So if there are no more questions, then I'm going to conclude this session. Online delegates, you can stay here for the next presentation in the stream or access another session through the event lobby. Thank you very much. Goodbye.